waiting for that. That was why I took this job. Good morning, everyone. Today is Tuesday, October 24th, 2023, and we've convened the Board of Health for the City of New York. The time is 10:07, and I'll call the meeting to order. We'll start with a roll call, and I'll call out members and just say here. Angelo Acquista.
Here.
Maida Galvez.
Here.
Rosa Maria Gill.
Here.
Sydney Hankerson. Here. Mitch Katz. Simona Kwan.
Here.
Michael Lindsay.
Here.
Gail Nailwith.
Here.
Judith Salerno.
Here.
Very good. Thank you so much. I'll start with a couple of opening remarks and then we'll proceed with the formal agenda. There are four things I want to cover in my remarks. Number one is the fall viral season. Obviously, you have seen that we have launched a very active vaccination campaign. It's very intentionally broadly focused on vaccination for respiratory viruses. That follows on our school vaccination campaign, which was launched at the beginning of September and the start of the new school year. We're all wrestling with the impact that COVID vaccination has had on overall vaccination rates. And so this is a really concerted effort to increase vaccination, especially amongst the highest risk groups for COVID in particular, people above 65, people with underlying disabilities, people who are pregnant, and people with underlying chronic conditions and immunosuppression. So very, very glad to see that numbers are actually going up in terms of uptake. We do expect a fall and winter viral season similar to that which we experienced last year. But for the first time entering the viral season, we have three vaccines and one antibody treatment to protect against RSV. In support of CDC guidance, we are recommending that people above 65 and parents of very small infants make the decision to either get the vaccine for RSV or to the monoclonal antibody for RSV in partnership with their healthcare provider, a primary care doctor or pediatrician. But this is a really good thing, and very, very pleased that we're centering that as we enter the fall, and we're starting early. So we're watching that very carefully. Our syndromic surveillance system and our ED surveillance system is active. Don't be surprised if we see similar data to last year, but we are more prepared than ever to manage it. Number two, as an update on mental health and some of the mental health work within the administration's mental health plan. You may have seen we issued an RFP, I believe 2 weeks ago, to double investment from the city into mental health clubhouses. These are community-based rehabilitation centers where the community itself is the therapy, where breaking social isolation is both an immediate therapy for people with serious mental illness, as well as a preventive for crisis. This represented a doubling of our investment into this system of care. The first time in over a decade that significant new resources had been put into this system. But as well with the RFP that's gone out, we're working to strengthen the system itself. As you know, community mental health often needs a lot of support in terms of administrative data collection, performance management. And so we're using this opportunity to both double the investment through a realignment of internal resources, as well as a strengthening of the underlying system so that we can do more. We can do more in years out. So we're very excited. We should be issuing those awards for the start of the next fiscal year. Second thing on the mental health plan update, in the coming weeks, we will have more to announce around the launch of the digital mental health platform for New York City high schoolers. This, as we said, is a front door program where any high school age student in New York, regardless of public school, private school, can log on and can receive immediate psychotherapy and counseling and if they are in need of higher level care, get connected into either crisis management and or site-based care in a school or site-based care in the community in partnership with Article 31 providers. So we're very excited about that launch. It's been many months of work and also finding the right technology partner to work with on this. So more to come in that space. And lastly, on mental health, the launch of 988, the 988 campaign, which most of you have seen. We're very glad that we're transitioning away from NYC Well into the federal hotline. New York City will be an exemplar for 988 implementation around the country, in part because of what NYC Well started, which is to build a basic infrastructure and connections into community-based supports for mental health services for all ages and all needs. And so I'm confident that in the next years to come, that 988 will become as ubiquitous as 911 is for other types of emergencies. So very, very glad that we're pushing in that front. Number 3 is public health data. I've said publicly and certainly internally, strengthening our data infrastructure coming out of COVID is a priority. And so this week, we will be making an announcement about some of the new structures we've created around population health surveillance and data infrastructure here at the health department, so that the data that we collect, much as we did for COVID in an emergency, represents not only information for people, but really information we can use for collective action and targeting of resources. So more to come in that space. And lastly, life expectancy. You've heard me talk about lifespan and health span as key challenges for our city to regain years of lifespan lost during COVID, but also to address the impact on lifespan and health span of parallel pandemics, such as overdoses, suicides, and underlying mental health conditions, chronic illnesses, widening birth inequities, and so forth. The data is clear that we've suffered greatly in the COVID era, and it isn't inevitable that we'll just get back to where we were prior to COVID. And frankly, the story prior to COVID wasn't all that rosy. In the last decade, we have seen a rise in deaths of despair due to suicide, overdose, and alcoholism, just to name a few. And so in the coming days, we will be making some announcements around the department and the city's effort to organize itself around getting back those years of lifespan lost and putting us on a track for healthier, longer lives for all New Yorkers. So with that, any questions around or any comments to respond to my opening remarks? Okay, very good. So let's move on to the formal part of the agenda. Let's start with the approval of the minutes from the June 15th, 2023 meeting. Are there any corrections to the minutes? If there are no corrections, then we can have a motion to approve the minutes as distributed.
So moved.
Any seconds? Second. All in favor?
Aye.
Very good. The motion passes. The minutes from the June 15 meeting are approved as distributed. On to the agenda. First item on the agenda is a proposal to amend Article 11 of the New York City Health Code regarding reportable diseases. Our presenter is Dr. Celia Quinn, Deputy Commissioner for the Division of Disease Control, and I'll turn the meeting over to Dr. Quinn now.
Good morning. Morning. This chair is very tall. Good morning, everyone. So nice to see everybody in person. So as the commissioner stated, I'm here to talk about some proposed amendments related to disease reporting. The first one I'll be talking about is a notice of adoption. So the proposal that we're proposing to be adopted today is to amend the health code to require laboratories to report all positive alpha-gal syndrome, or APS, and carbapenem-resistant organism test results. So as a reminder, the Board of Health approved the publication of these proposed rules in June of this year. A public hearing was held July 21st, and no comments were offered at the public hearing, and no written comments were received on this proposal. So as a reminder, the proposal related to AGS, this syndrome is a serious allergic reaction to meat products, and evidence suggests that this syndrome is triggered by the bite of a Lone Star tick. The burden of this condition is not well known in the US, but the CDC reported an estimated 110,000 suspect cases in the US between 2010 and 2022. So reporting the positive AGS results here will help us improve the knowledge of disease incidence and prevalence in New York City, enable targeted education and outreach, and can inform our tick surveillance program. And as a reminder, the CRO proposal, so the carbapenem-resistant organisms are bacteria that are resistant to carbapenem antibiotics. So that severely limits treatment options for patients that have this bacterial infection. These infections usually occur in hospitals, nursing homes, or other high acuity settings and can result in extended hospitalization, medical complications, and even death. The data about the overall burden of CRO in the US are limited, but there have been large outbreaks across the country. And reporting all positive CRO test results will improve our understanding of the burden, transmission, and evolution of carbapenem resistance in New York City and help us to identify cases and outbreaks to ensure rapid implementation of infection control precautions and limit the impact of these outbreaks. So we'll now have discussion on this proposal.
What's the mechanism for the labs to report this? Is it the same as what they're doing with other diseases?
That's right. It would be reported electronically through our electronic lab reporting system.
You have a sense for, in each case, what who is most at risk in terms of?
Right, because it's not reportable, we actually don't know much about that, but having it become reportable would really help us learn about that.
For both issues or just the one?
Right, so for both issues, yes. I mean, like I mentioned, we know that the resistant organisms are more likely to occur in healthcare settings. And then the tick-borne illness proposal, yeah, we would hopefully learn more about who's more susceptible.
How many cases of alpha-gal syndrome seen in New York City past 12 months?
Right, we don't know because it's not reportable.
So there are no estimates.
Correct.
Although this is something that this population health data infrastructure would try to answer, because most of what we know is based on reportable conditions mandated by law of health facilities. We're trying to expand that beyond. So while we work on this issue of reporting, we're also looking to strengthen our ability to look into non-reportable conditions.
Would there be an opportunity to share data with adjoining geographic areas? Because, you know, looking at the city limits alone might give a limited view, and it could be informative but I don't know if other jurisdictions nearby are reporting, or even New York State.
Yeah, so that's a really important question. This year, the Council for State and Territorial Epidemiologists has like a work group that's working on this and came up with a case definition for alpha-gal syndrome. That's one of the things that helps make it reportable. And so we would certainly be sharing our information through the Council for State and Territorial Epidemiologists nationally, but also with our partners in closer to us. And additionally, New York State is an important member of the CSD work group as well. So they're very enthusiastic about us being able to make this reportable.
I think to your point, Michael, though, we do know more data around other tick-borne conditions and exposure to ticks. So not that this would be equal, not that this would be the same, but at least may give you directionally a sense of if there are equity issues within the data.
How's the diagnosis made?
Yeah, so we'd be making a lab test report. So it'd be testing for antibodies against the alpha-gal peptide. Doctors may also do allergy skin testing, et cetera, to help to make the diagnosis, but we would not be making that reportable at this time. We're only asking to make the lab testing.
Do you have a sense of who's making those diagnoses? Is it an emergency room? Is it subspecialist? Or
it will be very interesting to find that out once we make it reportable. We'll know who the ordering physicians are, as well as which labs are doing the test.
Great.
Any other comments or questions? Can I have a motion to approve the proposed resolution to amend Article 11 of the New York City Health Code for publication and comment?
So moved.
Second,
Second.
all in favor?
Aye.
Any opposed? Okay, very good. Unanimous vote, motion carries. Okay, next item on the agenda is a proposal to amend Article 13 of the New York City Health Code regarding
I do have a few.
Whatever. There's one more on 11, isn't there? Yes.
There is, yeah.
We have another amendment on Article 11 for the New York City Health Code.
Yes, so these will be notices of intention for these amendments. The first one relates to CRO reporting in animals. So we just talked about carbapenem resistant organisms for people, but this proposal will be to add CRO to the health code list of reportable diseases for animals, which would make it reportable by veterinarians, animal care professionals, and veterinary diagnostic labs. So within the New York City Health Code, we do have some animal disease reporting, and section 11.25 lists the animal diseases that are reportable to the department. And these reports are required to be made by a veterinarian, a veterinary technician, a person of an animal hospital, rehab facility, animal shelters, or other facilities that provide care to animals, a veterinary diagnostic laboratory, or their designees. So CRO in animals, we have seen outbreaks among animals in the US, including in a Philadelphia veterinary hospital and in a Wisconsin animal rescue facility. So the human public health risk from animal CRO infections is unknown, but we do know that CRO transmission across species can occur. And there have been documented cases of suspected transmission, including a veterinary professional and their patients in Switzerland and an owner and their 2 dogs in Finland. So in terms of what the impact here is here in New York City, again, because it is not reportable, the overall burden of CRO in New York City animals is not known. But one New York City veterinary diagnostic laboratory found 256 isolates of concern among cats and dogs during the period 2019 to 2022, which was about 0.8% of their tested isolates. So our rationale for this proposal is that it is consistent with the One Health approach, which is the idea that the health of people is connected to the health of animals and our shared environment. This proposal would allow the department to monitor CRO trends in animals and better understand the burden in animals, as well as potential public health risks to people, and can help us to identify clusters and provide support to animal facilities to prevent the spread of CRO and limit outbreaks early. And could also inform our guidance and interventions for prevention and containment in different kinds of settings. So this vote is to approve for publication in the city record this proposed amendment to add CRO to the health code list of reportable diseases in animals, making it reportable by veterinarians, animal care professionals, and veterinary diagnostic labs.
Okay, very good. Any questions from the board or comments? Okay, can I have a motion to approve the proposed resolution to amend Article 11?
So moved.
Second,
Second.
all in favor?
Aye.
Opposed? Okay, very good. The motion passes.
Okay, thank you. All right, this next one is going to be about reporting of syphilis, hepatitis B, and hepatitis C test results. So this proposal is to amend the health code to require laboratories to report all negative syphilis test results, negative and indeterminate hepatitis B E antigen and surface antigen test results, and all negative and indeterminate hepatitis C antibody test results. So I'll talk about each of these. For syphilis, in 2021, there were nearly 10,000 reported cases of syphilis, and that included 24 cases of congenital syphilis. And untreated syphilis is a serious condition that can damage heart, brain, and other organs and lead to life-threatening conditions. The testing and diagnosis for syphilis is complex, and so negative test results can help differentiate between evidence of prior infection and a reinfection, and can help clinicians to stage the disease. Also important to note that delays in diagnosis of syphilis can result in delays in treatment and also contact tracing, leading to worse health outcomes for patients and their sexual partners, and increases the risk of onward transmission. So currently, most syphilis test results are required to be reported to the health department by laboratories. That includes all positive test results and indeterminate test results for syphilis. Negative test results that are associated with a current positive or indeterminate test result are also required to be reported. But the proposed amendment would require laboratories to additionally report all negative test results. So we're making this proposal in order to improve health outcomes for patients with syphilis and their sexual partners. It will allow the department to monitor compliance with required testing of pregnant persons for syphilis to prevent congenital syphilis, help us to identify to educate providers about this requirement, and to monitor whether infants who are exposed to syphilis receive the recommended follow-up testing. Next, I'll talk about hepatitis B. So there are an estimated more than 240,000 people living with chronic hepatitis B in New York City, with more than 5,000 new cases reported in 2021. So most people who acquire hepatitis B as adults will clear the virus on their own, but many progress to chronic hepatitis B, which can lead to serious health issues like cirrhosis and liver cancer. The hepatitis B antigen and the surface antigen, which are part of this proposal, are used for diagnosis, disease monitoring, and treatment eligibility determinations, and also used for case classification by the department. So currently, most hepatitis B results are already reported to us by laboratories. This includes all positive test results, negative and indeterminate hepatitis B DNA test results, and negative and indeterminate surface antigen and surface antibody test results for children under 5. And this proposed amendment would require laboratories to additionally report all negative and indeterminate E antigen and surface antigen test results. So we are making this proposal to allow for the department to review the appropriateness of testing and linkage to care at a population level, which would help us to identify gaps in care, develop targeted intervention to increase linkages to care, and identify opportunities to improve provider knowledge of hepatitis B testing and treatment guidelines, leading to improved disease monitoring for hepatitis B. And lastly, the hepatitis C. So more than 86,000 people are living with chronic hep C in New York City, with nearly 3,000 new cases reported in 2021. And about 85% of people who acquire hep C as an adult will develop chronic hepatitis C, which again leads to serious health issues such as cirrhosis and liver cancer if not treated. Hepatitis C antibody testing can help to identify new acute cases so that people can start care and treatment, and also help us identify outbreaks to limit those. So most hepatitis C test results are currently required to be reported by laboratories. That does include all positive test results for all test types and negative and indeterminate nucleic acid amplification test results. So this proposed amendment would require laboratories to also report all negative and indeterminate hepatitis C antibody test results. So this proposal will improve the department's ability to differentiate between acute and chronic infections in our surveillance. It will help us better identify recent transmission, which will help to improve detection of case clusters. It can help us to improve the understanding of the disease burden in New York City, and also inform hepatitis C screenings and targeted outreach to address inequities in C outcomes. And further, it can support earlier linkages to care and treatment, improving outcomes for individuals and reducing the risk of onward transmission of hepatitis. Okay, so this proposal is to approve for publication in City Record this proposed amendment to the health code, which would be to require laboratories to report negative syphilis test results, negative and indeterminate hepatitis B E antigen and surface antigen test results, and all negative and indeterminate hepatitis C antibody test results. Happy to take questions.
One question I have.
Go ahead.
I don't fully follow the indeterminate results. What does that mean?
Yeah, so the lab is testing for the presence of antibodies, or in some cases antigen, and depending on like the level that is seen, it can be described as detected or undetected, and sometimes it's indeterminate.
And so we would report that?
We would have those reported along with the negative test results. Often a clinician will repeat that result to try to see if they can, get a negative or a positive on that particular test. But overall, the diagnosis for hepatitis is complex. There's a lot of different lab results. I'll admit it's my least favorite word question. But there's, a clinician and also our surveillance experts are trying to look at all of the different available results to help determine, like, is this an acute infection? Is this a chronic infection? And it's especially important as we now have treatment, especially for hepatitis C.
If I can also I think COVID has taught us when and when it isn't important to have a denominator of tests, right? And I think what we are saying with each of these, what Celia is proposing is that from a population health planning perspective, from a resource allocation perspective, from a program development perspective, let alone from a clinical perspective, having these reportable negative tests and indeterminate tests will help us do that. especially because these are solvable issues.
Yes.
Right? There's a treatment and a cure for hep C, for syphilis. There are ways to control hep B that are, and these are all preventable morbidity and mortality. So becomes pretty essential, which is different to a fast moving respiratory virus, which is decreasing in its morbidity and mortality over time.
So I routinely, certain patient populations screen for hepatitis B.
Yeah.
You know, where does that fall into in terms of the reporting process? As that's going to be positive in many cases that have been immunized. So how do you interpret that?
Right, so having the negative test as well as the positive test that we get will help the department to classify the test results as, immunized, previously infected, acute infection. And that helps us to prioritize our resources in terms of where to invest in helping to make connections to care for, especially early onset acute cases where, earlier intervention can be helpful. And you're right, there are new recommendations about hepatitis B screening. So this can also help us to, having the negative test results will also help the department to understand where is that screening not being implemented as fully as it should be.
In 2021, it went under the radar because of COVID. We published a elimination of viral hepatitis plan. And without these data, it's very hard for us to proceed on a path where we could eventually one day see the elimination of these viruses and their morbidity and mortality. So it seems like a small thing, but it's actually a big thing. But to your point, Doctor, from the health system perspective, you've got your cohort of patients. And so you're dealing with your cohort. And then, of course, as a clinician, you're dealing with your patient. But from a citywide perspective, I need a way to link your data with Mount Sinai's data, with NYU's data, with Columbia's data, and then say, okay, here's the universe of hepatitis C patients or hepatitis B patients. And right now we don't have that. We only have that for positive cases. And it's only built on the fact that it's mandated in the health code. So what we're saying is, if we really want to drill down on these remaining cases, we really need this is a natural way to link the data for us. And you don't have that natural access, right? Epic, I know, creates ways to do this, but it's not in anyone's single view. And the big logic here is that the health department needs to be the single view on health in the city of New York. Not your system or your system or your system or your system. We're the health department. That's our job. This is the underpinnings of that.
I think this makes a lot of sense to do a negative point of curiosity, because I know for syphilis, it's part of a workup for first episode psychosis. So just wondering, in terms of the epidemiology, are you seeing that more new incidents in younger age groups or older age groups? Just wondering if you have that data.
Yeah, we probably do. I don't have it in front of me,
Okay.
so I'm not able to answer your question right now, but we can look into that.
That's a very interesting question.
Yeah.
Okay. Any other comments or points for discussion? Can I have a motion to approve the proposed proposed amendment to Article 13?
So moved.
Second.
All in favor?
Aye.
Any
Aye.
opposed? Okay, great. The motion passes.
Thank you.
Very good. Okay, the final item on the agenda, approval of a proposed resolution to amend Article 203. Thank you, Dr. Quinn. To amend Article 203 regarding termination of pregnancy. Our presenter is Gretchen Van Wy, Assistant Commissioner within the Bureau of Vital Statistics, newly appointed Chief Epidemiologist of the Health Department. And we'll turn this over to Dr. Van Wy.
Great. So good morning. It's great to be with you in person today. I'm going to go ahead and talk about what we're proposing for Article 203 of the Health Code. It's about medication abortions, which are actually already reported to the department. This is just making it a little bit more explicit that needs to be done. So as background, more than half of abortions in the country are actually medical. And a medication-induced termination of pregnancy involves these prescription drugs that are intentionally to end a pregnancy. And the most common ITOP, what we call an induced termination of pregnancy, is a two-drug regimen that uses mifepristone and misoprostol and it's approved by the FDA through 10 weeks of pregnancy. So the recent history of the drug combination is that mifepristone was approved by the FDA in 2000. In 2016, FDA no longer required the mifepristone to be taken in the clinician's office. So in 2021, FDA allowed patients to receive the medication either in person or via mail. And so since 2021, with the removal of the requirement for in-person dispensing, telemedicine has become increasingly important in this realm. And so we've been consulted recently by telemedicine providers specifically. But like I said, providers are reporting medication abortions to us, and you can just see here that the pink line on the bottom is the increase that we've seen over the past 10 years or so in medication abortion, while we've seen a decrease in surgical and procedural abortions. And of course, there's an overall secular trend downward in terminations of pregnancy because of a lot of different factors related to pregnancy prevention. So in terms of legal background, in June of 2022, after the Dobbs decision, the state and the city took legislative action to protect patients seeking abortion. Also those who are helping people obtain abortions. And so ITOP reporting, ITOPs occurring in the city, of course, have to be reported to us through Article 203. And these are something that we reviewed in light of the recent attention to this topic and because of the questions that we've gotten from telemedicine providers. So currently, Article 203 of the Health Code specifies that the New York City's termination of pregnancy in 20303A, it refers to an ITOP event is that it involves attendance by a healthcare provider either at the event or en route to the facility where the event would occur, or at the medical examiner's office. So obviously this is different. The paradigm's different when we're looking at telemedicine. And there's no explicit provision for reporting of medication ITOP. And so, as I mentioned, existing healthcare providers reached out to us and said, should I really be doing here? So that's why I'm here today. And what I'd like to propose is that we just include medication ITOPs explicitly within the definition of ITOP. That we clarify that the provider must report medication ITOPs to the department when they're prescribed at the time that they're doing the ordering. Specify the timing, because not only do we want the fact of these events, but we want these data in a timely fashion. And then we want to propose some typos to the health code we want to add some words that were from the recently amended 20307A section. So we propose that 20301 will be amended to include a statement that just says the definition includes medication-induced termination of pregnancy as defined in this article. Subsequently, farther down in subsection F, we'd say medication-induced termination of pregnancy means an induced termination of pregnancy using medication prescribed or ordered by a licensed healthcare provider. A medication-induced termination of pregnancy occurs in the city when a licensed healthcare practitioner prescribes or orders the medication for a patient, regardless of the location of such patient when the medication is taken. We'll also propose in section 203 an amendment to include the following. If the event is a medication-induced termination of pregnancy by the licensed healthcare provider prescribing the medication. This is just so the provider knows that they need to do this. And then in part C, we'd have, which is farther down, removing section B there, we'd say a certificate of termination of pregnancy required by this section shall be filed within 24 hours after the event if a disposition permit, and then goes on and it includes within 5 business days. So this is just the timeliness portion of it. So it's a little bit of a long paragraph there, but timeliness is the point. And this is where we also are going to make that addition with the word certificate and to 20307. So just you can see that underlined part. So I'd like to ask if you have any questions, and I'd like to ask for a vote to approve for publication in the city record these proposals.
Sorry, I have a clarifying question. One of the items said that in the event the chief medical officer investigates, what would trigger an investigation by the chief medical?
Sure. So the medical examiner's office is the we're referring to there. They investigate anytime a pregnant person dies.
Okay.
They also, so that's one thing, but also any kind of so there's like suspicious death, accidents, homicides, things like that.
So it's death related.
Mhm.
Got it.
There's a question.
Oh, yes.
Judy.
Yes, quick question. If the medication is prescribed and reported, you have no way of knowing if the person decided to take the medication or didn't. I presume there's no way, no feedback on that?
That's correct. I mean, the reality is that we'll know the event, and the event is defined as the prescription of it.
And not the pickup, actual pickup.
Correct.
Yeah, there isn't a condition I can think of where dispensing is
Yeah.
the surveillance.
And this essentially is just to conform with current practice.
Yes, exactly.
And it's especially important given that we've expanded access to medication abortion in our public health clinics, and public hospital has expanded it through telehealth. Same sort of principle. If we don't see the whole universe of cases, it's very hard for us to allocate resources, to track inequities, and to make sure that we're providing the services where they're needed most. Our ability to make adjustments falls when we don't have.
Thank you.
Okay, so can we have a motion to approve?
To move.
Second.
All in favor?
Aye.
Any opposed? Okay, the motion passes unanimously. That brings our meeting to a close very efficiently, I have to say, in 45 minutes. I thank you for your attendance. It's very lovely to see you all in person. And I look forward to doing it again soon. And this meeting is adjourned. Yeah.
So will they move to having
Now we have to join for that.
attendees be?
People want them.
Yeah.
Yes, we should.
They can tune in. But
Yeah, I think